Lena, if you want to think. Welcome to the second session of the PPCL ECHO program. My name is Jody West, and I will be your coordinator for today's ECHO. I want to go over a few housekeeping items before we get started. As I've already asked, but if you're just joining, go ahead and enter your name, organization, title, and email address in the chat box for attendance. This is going to be our agenda today. We're going to do our best to adhere to this. It has a lot of content, so we're going to go pretty quickly through some items, but we also want to be able to spend some time as needed. I will complete these announcements, and our facilitator, Dr. Olivier, will lead us in introductions, and then pass to Margaret Smith, who has graciously agreed to and volunteered to present our case today. When after she presents, we'll open the floor for clarifying questions from the participants and then the hub team. After any questions have been answered, we'll go to transition. We'll transition to recommendations. We'll briefly summarize those recommendations and then pass the presentation and the didactic on to Dr. Roy. And then we'll have announcements and wrap up for the session. Dr. Olivier?
Hey everyone, I'm Dr. Olivier. I'm a child and adolescent psychiatrist here in Lafayette and have a private practice over here. And I previously worked for LSU Health Sciences Center in New Orleans. I'm the facilitator, so I'm the one who tries to make sure we stay on schedule and protect HIPAA. And so this is the part I'm going to call each of you out for. The rest of the presentation, I will not call you out, so pay attention and just briefly introduce yourself, because we like to get to know y'all as we do these presentations over the course of the months. But you met Jody West, she's our coordinator. I'm gonna ask the rest of the hub team to introduce themselves, starting with Lena.
Hi, everybody. My name is Lena Riggett. I am a social worker, and I am the mental health consultant for the provider-to-provider consultation line. And I'm also one of the hub team members. So I'll be doing a lot of TA today, making sure everyone enters all their information so we can get surveys and CEUs to you at the end of the session. So thanks for having me.
Dr. Queen.
Hi, I'm Dr. Katie Queen. I'm a general pediatrician. Went to LSU Pediatrics. I practice in rural pediatric clinic in Bogalusa. And just like you guys, I was a participant in the first cohort of the Project ECHO and loved it so much that I wanted to join in, and they asked me to be a faculty. So I'm honored to be here.
All right, Lisa.
Hi, I'm Lisa Spence. I am a nurse practitioner at St. Bernard Community Health Center. I do primary care and behavioral health.
Thanks, Lisa. And Paulette Carter.
Hi, Paulette Carter. I'm a program manager with the Bureau of Family Health.
All right, welcome. And Dr. Roy.
I'm Cody Roy. I'm a child and adolescent psychiatrist and training director at LSU Child Psychiatry.
Dr. Roy is giving our didactic presentations today.
That's right.
Right. I see Brittany Santora.
Hi, I'm an LPSW with Red Stick Pediatrics, and we're an integrated health pediatrician and behavioral health clinic.
Welcome. I see a Christian Narcisse.
Hi, I'm Christian Narcisse. I am an LMSW and I work for Lafayette Parish School System as a school social worker.
Welcome. How about Courtney Campbell?
Hi, I'm Courtney Campbell. I'm one of the general pediatricians in Baton Rouge at the Lake Pediatric Academic Clinic with residents.
Welcome, Dr. Campbell. How about Dr. Barton?
Hi, I'm Tonya Barton. I'm a pediatrician at Rush Central Clinic in Meridian, Mississippi, now a part of the Ochsner community. And this is my first time on here, so I'm really excited.
Awesome, welcome. Woo, crossing state lines now.
Woohoo!
Yes.
How about Pamela Field?
Hi, I am a social worker, school-based health centers and schools with Our Lady of the Lake in Baton Rouge.
All right, welcome.
Thank you.
I see Jen Bordelon.
Hey, Jen Bordelon here. I am LCSW and LAC by training, and I'm serving as the PPCL's resource specialist.
Awesome, welcome. welcome back. I'm recognizing. Sorry. Let's see, Catherine Wise. Sorry, I think so. There's still some people rolling in, so sorry if I'm like calling you out right as you're rolling in. But there are a few others. If anyone else wants to chime in real quick and introduce themselves, if anyone I missed, go ahead.
Oh, I sure can, because I just hopped in. So my name is Catherine. I'm an LPC and I work at the Family Tree in Lafayette. And I see majority kiddos.
Welcome. Anyone else I missed? And I apologize if I missed you, because the participants are kind of rolling through as more people join in.
Okay, hello, I'm Leslie Brazier. I think I missed the last one, but I attended the first one. I'm a pediatric nurse practitioner at Pelican Pediatrics in North Louisiana and Homer. And I provide medical care, but we have some behavioral health specialists on staff here too.
Awesome, glad to have you. We got North Louisiana in the house. Email it. But we'll go right into Dr. Roy. This is one of the few times that the case coincides with what the topic of the didactic is. So Dr. Roy, it's your show.
Thank you. And what time do I go till?
12:58.
I wanted to just sort of add something at the front end of this to the discourse that's been going on, is that one thing I've been trying to be really cognizant over the last few years is making sure that I'm not introducing bias into mental health. And so I agree that parenting solutions are sustainable and much more valuable than medications over time. On the other hand, are we consistent? Like if a child's got breathing problems, are we not going to treat it till their parents stop smoking? I don't like the idea of hanging programs over parents' heads to get treatment. Everything else in medicine we want quick fixes, right? We're not going to say we're going to let that bone heal on its own to teach you a lesson about, riding your bike in the road. So I just would introduce the idea of adopting a philosophy of consistency across all, psychiatry and all pediatrics in general. But anyway, practical parenting tactics for kids with oppositional defiant disorder. I did not go into psychiatry to be a parenting expert. You'd asked me 20 years ago, I just said, that sounds so boring. I have no interest in that. And that's almost everything I do now, because I find there really is no sustainable pediatric mental health wellness without engagement with the family. So joke's on me. And this idea of oppositional defiant disorder and behavior disorders in general is an entire textbook, which I'm not going to cover in a few minutes here. So I just have a few key points and want to hopefully save some time for questions. One of the problems we run into as practitioners is we don't spend enough time on the nomenclature up front. That often everyone in the room is saying behavior problems, but they're talking about different things. But we're all smiling and nodding as if we're saying the same things. It's sort of like if you're out with somebody and you're both, I love you too, and but that means very different things to the both of you, right? So behavior problems are the manifestation of basically any problem a child's having, right? 110% of children that come to my clinic are presenting for behavior problems. Now, sometimes those behavior problems are a manifestation of a diagnosis, ADHD, ODD, anxiety, but sometimes it's just stress in the environment, boredom, hunger, frustration. And for a lot of our families, kids live perpetually in a stressed environment. So you can advance the slide. I love this. I can't see the bottom, it's cut off, but this, and hopefully I can sum this up. This is a timeline of pediatric mental health disorders. I would just, if you have access to these slides, just post it on your wall. This is a very reliable tool as to when diagnoses present, so that, if a child's telling you they're hearing voices at 6 years old, it's not schizophrenia. That's not going to show up till 14 at the earliest. From birth, we have the neurodevelopmental disorders, ADHD, intellectual disability, and autism. And disruptive behavior disorders in the pink there, ODD, conduct disorders, start to show up around 4, 5, or 6. So if you have a 6-year-old in your office, the nice thing is there's very few things that this is actually going to be. Now they all might manifest in weird ways, But if the 6-year-old come into my office saying they're hearing voices and they're seeing a bloody monster, I know this is ADHD, ODD, intellectual disability, or autism, right? I know this isn't depression or schizophrenia, maybe separation anxiety. But there's just a kind of a helpful tool to kind of orient ourselves. And these behavior issues start pretty early on. Next slide, please. When we're talking about behavior problems, the very first thing is just to get on the same page about what we're talking about. Do you mean they're aggressive? Do you mean they lie and you don't like that? But they whine, or they're not doing what you say? These are all very different things that require very different interventions. So we want to be careful not to kind of lump these together and just say this child has behavior problems, because they end up kind of getting funneled through a treatment line with interventions that maybe aren't really specific to the challenge the kids are having. Next slide, please. Why do behavior problems occur in a child? 4 reasons. 1, they're just not good at self-regulation. 2, they don't have good communication and language skills, so they aren't able to put things into words. They just manifest it in theatrics. They're not very creative. I know when I'm having a bad day, I have all sorts of passive-aggressive solutions to letting out my frustration, but children don't. They just kind of yell and scream and stomp around. And lastly, children have behavior problems because behavior problems work, which means that they're reinforced in some way. Next slide, please. And this is just saying that behavior problems lead to more behavior problems, and I'll kind of explain what I mean by that on the next slide. This is sort of the holy grail. It's the mathematic equation to describe all behavior, good and bad, since the beginning of time. So it's a really simple way to think about a behavior challenge that somebody is having, this ABC model. Antecedent is what's the thing that happens before. So the mailman walks up to the door. Behavior is the target behavior. My dog starts barking, that's the B. And then consequences, what is the thing that happens immediately after? So maybe I swap my dog's butt with a newspaper, or maybe I give them a treat. So consequences are what happen right after the behavior. Next slide, please. And what reinforces, guides, and creates behavior is that consequence. It's not the antecedent, it's not the behavior itself, it's what follows from that behavior. I used to run the little kids unit in the inpatient hospital. You can go back to slide, Children's Hospital. And there were kids who were very socially anxious and they didn't want to go to groups. And so they would do silly things. They'd slide out of their chair, they'd make fart jokes, and we would send them out of groups, right, as what we thought was sort of a punishing consequence. But in fact, they were very pleased because they no longer had to feel the discomfort of their social anxiety. So inadvertently, we were adding to that annoying behavior by reinforcing it. And this is sort of how oppositional defiant disorder and behavior disorders start, probably from birth, is that parents who are stressed, overwhelmed, under-resourced with very good intentions are inadvertently reinforcing behaviors that later become problems. If my child's in the grocery store and they want a Snickers bar and I say no, and they say, give me a Snickers bar. And I say no, and they say, give me a Snickers bar, damn it. And I say, fine. I might be yelling at them and cursing and thinking, well, they're not going to do it next time. But all I've done is taught them, oh, you have to ask 3 times for a Snickers bar for dad to give it to you. So this kind of stuff is going on all the time in homes and is what's likely contributing to the diagnosis oppositional defiant disorder or behavior issues in the beginning. And this dynamic is often set up by just what we think of as a goodness of fit or issues with the child's natural temperament not matching their parents is kind of how this gets started in the beginning. Next slide, please. When I'm thinking about supporting families with parenting, there's just 2 things I'm always doing. And so there's a lot of ways to do it. There's different books and all kinds of weeds you can get into, but there's really just 2 things. And number 1 thing is I'm always trying to nudge parents toward a more authoritative parenting style. So that's number 1. Next slide, please. So these are the kind of 4 parenting styles. This has also been described for teaching styles. So on the right-hand side, we have parenting styles that are kind of warm and supportive and engaging, authoritative and permissive. On the left, we have kind of cold and distant parenting styles. And on the top, we have parenting styles where there's rules and expectations, and on the bottom, not so much. Next slide, please. I feel like I'm talking like one of those auction people. Who wants authoritative parenting? Authoritative parents, parents who have the style consistently across time seem to have much fewer of all kinds of psychiatric issues in their kids, anxiety disorders, mood disorders, but especially behavior disorders. So these are parents that have clear and consistent expectations. They're democratic in things. How can we solve this together? They're patient. They have rules, but they're flexible. So parents who can adopt this as a philosophy of relating with their children tend to do much better. Next slide, please. As opposed to parents who are permissive, they're warm, but they just sort of allow their kids to do as they please, poor boundaries, rules that are unclear, parents who have this idea of, I don't want them to be mad at me or I'm the cool parent. Those kids tend to have more behavior problems. Next slide. Uninvolved parents. So these are parents who are not warm or engaged. These are often parents who have mental health problems, substance abuse issues, or other major psychosocial stressors that prevent them from being engaged in parenting. Those kids don't do well. And then lastly, next slide, please. This group's kind of difficult because these parents strongly feel that they're engaged in optimal parenting, but this is sort of a, it's my way or the highway kind of parenting. These kids often respond in not great ways, either by internalizing with anxiety, and do those sorts of things, or externalizing by acting out and being defiant, and sort of pushing back against this style. So that's first thing I'm always thinking about, is moving them towards authoritative parenting. And then the second thing is really just getting away from punishments altogether. Punishments really have no value. If my kid's jumping on the couch and I whoop them on the butt, they might be afraid of me, but that doesn't get rid of their urge to move and groove. And it also doesn't teach them what I'd rather them be doing. So there's not really any value in punishments. There's a lot of value in rewarding. If you think back to that ABC, that consequence, if it's rewards, can really strongly shape behavior. Next slide, please. Oh, this is the good news, is that from my opinion, I don't know, Dr. Olivia, if you disagree, but I wouldn't expect anybody on this call to solve oppositional defiant disorder or behavior disorders. These have occurred over time. They're relational, they're entrenched in the family system, and even more, they're entrenched in social systems, right? Because these families are stressed and they're under-resourced. So I would, sort of take a sigh of relief and think nobody's expecting anybody here, primary care provider especially, to solve these problems. And the psychiatrists don't have time to work with these family systems and relational issues. Next slide. But these are some hot tips, things that we can do, things that y'all can do when these cases are presenting. So first, don't get sucked into this why trap. It doesn't matter why this problem exists. Sending them to play therapy is not going to help. A deep exploration of their internal fantasies and fears is not going to solve this relational issue, which is happening through reinforcement. So if the solution is not a behavior plan with parent training, it's not going to help. Next. Don't be afraid. There's already good resources out there, so you don't have to come up with stuff. Just choose a book you like and read it. It's got a million things in it. These are the 4 that I most commonly use. And I feel like if a parent's coming to me asking for help with a behavior issue and they're not willing to put some skin in the game themselves, then there's nothing I'm going to do that's going to help them anyway. So find something like, this is super important. This is the #1 thing that kind of causes me frustration is don't call it something else. If this is oppositional defiant disorder, I think there's a slippery slope where we say, well, maybe it's blank and I can treat that blank, right? And then what happens is we sort of never identify this relational issue as being the core problem. So don't be afraid to say, I think this is an issue about the relationship between the 2 of you, and that's linked to behavior issues. And here's resources for that, or here's the next step. I think sometimes we feel like we need to do something now. The next tip is a little contradictory to that, but if somebody you feel really meets the criteria for some other psychiatric issue, often treating those will significantly, or at least modestly, improve the behavior issues. So like in this case presentation, I would have absolutely treated the ADHD. You've got the Vanderbilts, you've got a good description of ADHD. Go ahead and treat it. Being clear about ADHD is hyperactivity and inattention. But sometimes kids that are hyperactive and inattentive act out because they're frustrated that they're having to do double duty to pay attention in class, those sorts of things. So you can treat associated issues. Next slide. And I set the bar super low. So I'm not trying to fix anyone's behavior problems. I don't think kids are broken and those things aren't really fixable, but we can do some minimal things. And this is just a chart I made to kind of point out to parents. If you reduce, even if you didn't get rid of tantrums, if they went from 60 to 45 minutes a day, a parent gains 7 hours a month in non-tantrum time, right? Imagine what you could do with 7 hours a month. So, you know, we're just looking to improve this enough that these families can start moving forward with all the other stuff they have to do with paying the bills and figuring out how they're going to go ride somewhere. So I always set the expectations pretty low. And I never try and treat oppositional defiant disorder. I try and treat the problem that's the biggest pain point for the parent. It's like, yes, my child is oppositional defiant disorder, but if I could just get them to bed, I'd have a half hour to myself. So that's, I sort of shift the conversation towards specific interventions, and those are much easier to focus on. Next slide. This is just a summary. So there are optimal parenting strategies to reduce behavior problems. That's the authoritative parenting style, frequent praise, infrequent punishment, and then strategies for us. I just kind of went over, and I'll leave some time for questions if people have them. Oh, thank you. And that's my email. Anyone can email me anytime.
Thank you, Dr. Roy.
Yeah.
Any questions?
I don't know if I have a question, but I guess I have a comment. And, you know, I'm a social worker working with our 26 family medicine residents who see the very wide spectrum of cradle to the grave populations. And so I see significant hesitancy you know, a desire to get maybe a child psychiatrist on board, but like you said, it's not always a feasible option. But I think after hearing everything that y'all said about that case and your presentation, at least a consult with the PPCL child psychiatrist would probably be a great next step, because that is exactly what it's there for. We can't get them to that resource soon enough, but we shouldn't delay the care either. And I think some of the family medicine physicians, they just may need that extra support to be able to make the call to whatever, you know, the next step would be. So
yeah, absolutely. I just calculated the other day, I've seen about 8,000 kids and families since I've been doing this. So, you know, I have the confidence just because I've seen so many. So that's why I like these kinds of programs. It's when the first time you're seeing it, it feels so complex.
Right.
Yeah, and just for the participants that participate in ECHO, but not PPCL, the program that we host the ECHO for primary care providers for mental health, pediatric mental health programs, but like Margaret was alluding to, we are a call line. So statewide, providers can call and speak with either us as a social worker on these cases that we're like this, that we're discussing. And if need be, we can connect them to a child psychiatrist that we have contact with to talk about medication and diagnosis. So that's just a service that's available statewide, free for the next 4 years. So it's just something that the PPCL, that's what we do. So thank you, Margaret.
Thank you.
Any other questions for Dr. Roy? Well, we appreciate your time, Dr. Roy. Margaret, we appreciate your case presentation. I love that these coincided. It's great when the cases do have that synchrony. And our next session is in July. What we're going to do is send everyone a link that has, or Lena's going to put in the chat that if you need CMEs or CEUs, But our next presentation, we do need a case presenter. And our next session is about anxiety. So Lisa's going to present about screenings on anxiety and depression in a primary care setting. So is anyone on the call that thinks that they have a case they'd like to bring for the next echo to present it?
And Jody or I can happily walk you through how to fill out the form. It's really easy, so don't be scared to do so. Just let us know.
Reach out to us.
And Jody, if nobody has anything, I have a million, so just let me know. I can fill it out.
Okay, thank you. Well, again, we really appreciate your participation, your attendance. Margaret, thank you for bringing the case. Dr. Roy, thank you for giving your expertise. As Dr. Olivier, and for everyone else that shared their expertise and clarifications and recommendations. As Dr. Olivier stated, we will send out the recommendations from the participants to Margaret for this case, which happens after every case presentation. I'll also send out an email to all the participants. That's why we ask you for your email. That'll have the PDF of the slides of Dr. Roy presented, as well as the link for if you need CMEs or CEUs. You have to complete that within 48 hours for you to get credit. So thank you all so much for your attendance today and for your participation. Our next session is July 11th, and I will be sending out reminders to everyone. So we'll stay on for a little while if anybody does have questions or would like to speak about the case presentation. But thank you all so much, and I hope you have a good rest of your day. Bye.